শুরু করব। Good evening, ladies and gentlemen. I am Dr. Mohammedullah Firoz, Associate Professor of Cardiology, Sir Solimullah Medical College and Mitford Hospital. I welcome you all to this symposium on heart failure. We have got 4 brilliant speakers on this session. Professor Mohammad Abdul Qadir Akon from Sir Solimullah Medical College, Dr. Abial Hussaini from UK, Professor Upendra Kaul from India, and Dr. Resham Barua from UK. We have got some learned and experienced cardiologists from home and abroad as panel of experts. Professor Muhammad Nazrul Islam, formerly Director and Professor of Cardiology and NICVD, and UGC Professor, Bangladesh Bangabandhu Sheikh Mujib Medical University. Professor Abdullah Al Shafi Mujumdar, ex-Director, NICVD, and Secretary General of Bangladesh Cardiac Society. Professor Dr. Sajal Krishna Banerjee, Professor of Cardiology, BSMEMU, also Dean of Medicine Faculty, BSMEMU. Dr. Shuk Nier, who is the consultant cardiologist, Chelsea and Westminster Hospital, Imperial College London. He is also President of Royal Society of Medicine, Cardiology Section, Communication Lead, British Cardiovascular Society. Dr. N.A.M. Mominuzzaman, Chief Cardiac Consultant, United Hospital, Dhaka. He is also former President of Bangladesh Society of Cardiovascular Intervention. Professor Fuzilatun-Nisa Malik, Professor and Chief Consultant Cardiology, National Heart Foundation Hospital and Research Institute, Dhaka. Professor M. Atahar Ali, Professor of Cardiology from NICVD, now working as Senior Consultant, Evercare Hospital, Dhaka. Professor Dr. Mir Jamaluddin, Director and Professor of Cardiology, NICVD, Dhaka. Professor Dr. Abdul Wadud Choudhury, Professor of Cardiology and Head of the Department, Dhaka Medical College Hospital. And Dr. Munjur Shaukat, who is the Clinical Lecturer, Hammersmith Hospital, UK, and Faculty of Medicine. May I request Dr. Amiruzzaman Khan, Associate Professor of Cardiology, Sir Solimullah Medical College, to welcome our speakers, guests, and the attendees. Dr. Amiruzzaman Khan, please.
Thank you very much. Dear renowned speakers from home and abroad, panelists, participants, warm welcome to you all. Good evening, ladies and gentlemen. On behalf of Cardiology Department, Sir Solimullah Medical College and Mitford Hospital, it is my great pleasure and proud privilege to welcome you to the International Symposium on Heart Failure organized by Cardiology Department, Sir Solimullah Medical College and Mitford Hospital. Thank you to each and every one of you for being here with us today through this webinar during the hard days of COVID-19 pandemic, from which the whole world is now suffering. We are very pleased to be able to welcome those of you that have been with us for a long time now, as well as those who are new to the group. It is high time that such an event took place to highlight the remarkable contribution of number of researches on heart failure which take place in different hospitals and research institutes around the world. A number of distinguished cardiologists have joined our faculty here and will take part in this symposium from England and India. We hope this venture will provide wide scope to share our experiences and research findings on different chronic cases of heart failure in home and abroad. We hope that you will enjoy the conference, that will interaction with the colleagues from many different countries will stimulate a creative exchange of ideas and will be personally rewarding. Now I invite you to join the scientific session of this symposium and request Dr. Mohammedullah Firoz to conduct the session. Thank you very much.
Thank you, Dr. Amir Jawan Khan. We are in fact going through this COVID-19 pandemic. Some of the countries in the world like UK has taken good control of this COVID-19, but countries like Bangladesh, India, we are still struggling, and hopefully we'll overcome within short period. Our respect to all the healthcare workers who have suffered and are suffering from this COVID-19 and lost their lives in this pandemic. Ladies and gentlemen, heart failure is a global health problem. At the moment, at least 26 million people are suffering from the heart failure. We don't know exactly the data regarding Bangladesh, but at least 1% of our total population is suffering from heart failure, which amounts that more than 10 lakh, that means 1 million adult people are suffering from a heart failure in Bangladesh at the moment. There are also some differences regarding the demography of heart failure between the Western population and Bangladeshi population. Usually Bangladeshi heart failure patients suffer their diseases at least 10 years earlier than the Western population. In a hospital-based study, we have seen that around 50% of the heart failure patients hospitalized are less than 60 years of age. The main reason of their heart failure is ISD in 66% cases. In 16% cases, it is valvular heart disease, and in 8% cases, it is hypertension. This heart failure is important for us because it is reducing the lifespan of the patient. It is reducing the quality acquired life year of the patients. It has got also a great socioeconomic impact on our population also, because we have to count the cost of diagnosis and treatment of the heart failure, cost of work hour loss of our patients, loss of our care. More importantly, any of the heart before they attain the ability to spend and treat their patients. Ladies and gentlemen, this is the second session with heart failure from Sir Salimullah Medical College. In the first webinar session, Sir Abdul Qadir Akan talked about left heart failure, its clinical feature diagnosis and management. Today, we'll talk about other aspects of heart failure. Professor Abdul Qadir Akan, who is working as the head of the department and professor of cardiology, Sir Salimullah Medical College and Milford Hospital. He will be talking on right heart failure, dark side. May I request Professor Akan?
Thank you, Professor Mohammedullah Firozi. First of all, I express my gratitude to all the speakers and honorable panelists for attending this program. So today, so far my knowledge goes, the randomized trials, large-scale trials on right heart failure are lacking, and most guidelines did not focus on right heart failure and its management. So today, I will talk on chronic right heart failure, a dark zone. Right heart failure is the clinical syndrome of signs and symptoms due to RV dilatation and dysfunction. In introduction, we can see the 21 million adults worldwide are living with heart failure. The overall worldwide cost of the heart failure management is nearly 108 billion US dollar. And heart failure is the #1 cause of hospitalization in patients over 65 years of age. And the vast majority of the heart failure patient has got 3 or more comorbid conditions. And 50% of the heart failure patients die within 5 years from the diagnosis. So if we look at the incidence and prevalence in the whole globe, we can find that the incidence is highest in China, and prevalence is highest in Malaysia, and the lowest prevalence and incidence in India. And the author of that article commented that the very low incidence and prevalence in India may be underestimation of the heart failure in India. So if we look at the pathophysiology, the normal right ventricular function is governed by the systemic venous return pulmonary artery load, pericardial compliance, and contractility of the right ventricular free wall and interventricular septum. Generating RV output requires only 1/6 of the energy expenditure of the left ventricle. And right ventricular coronary perfusion occurs both in systole and diastole, that is different from the left ventricle. And RV overload increases the risk of myocardial ischemia. And this diagram shows the RV systolic function is highly sensitive, that minor changes in afterload increases the large change in the stroke volume, but that is not in left ventricle, because left ventricle can tolerate the change of afterload better than the right ventricle. So an imbalance occurs in three key neurohumoral systems in the pathogenesis. One is the sympathetic system, RAS system, and peptide systems. They initially plays the beneficial role to overcome the heart failure or compensate the heart failure. But later on, this compensatory mechanism may be detrimental. In that situation, controlling sympathetic function by the beta blocker, RAS by the ACE inhibitor, and peptide metabolism modification can play good role to protect the heart from the heart failure. So causes, if we look at the causes of the right heart failure, some decreases the contractilities like right ventricular cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy, or right ventricular infarction. Some increases the RV volume overload, including the pulmonary regurgitation, TGA, tricuspid regurgitation. And some increases the RV pressure overload like pericardial disease, chronic and left-sided heart failure, pulmonary stenosis, etc. And some overlaps like left heart disease increases the right ventricular overload as well as the right ventricular pressure overload, which happens also in single ventricle as well. And in Epstein anomaly, that decreases the RV contractility and increases the overload. So classification of the pulmonary hypertension is very important to understand the dysfunction and failure of the right ventricle. And pulmonary hypertension category basically divided into two. One is the pre-capillary, another is the post-capillary. And pulmonary mean artery pressure is more than 25 is required to make the diagnosis of pulmonary hypertension. So by PCW makes the difference the pre-capillary and post-capillary issues. In pre-capillary, the PCW is equal to or less than 15 millimeter mercury. And post-capillary, PCW is more than 25 millimeter mercury. Important is the clinical grouping or WHO class. In clinical grouping, group are divided into 5 groups. Group 1 is due to the intrinsic vascular disease of the pulmonary system. Group 2, secondary to the left heart disease. Group 3 is due to the pulmonary parenchymal disease like COPD and other causes. And group 4 are the thromboembolic diseases that produces pulmonary hypertension. And miscellaneous is the group 5. Staging of the heart failure is done by the ACC-AHA. Stage A, that means no feature of heart failure, no structural heart disease. But in stage B, there are structural heart disease without evidence of heart failure. And stage C is the symptomatic heart failure associated with underlying structural heart disease. And stage D is the advanced structural heart disease and marked symptom of heart failure at rest despite maximum medical therapy. Again, the heart failure is also classified on the basis of systolic function. That is the heart failure with reduced ejection fraction, preserved ejection fraction, and mid-range ejection fraction. That is very important in the management of left heart failure. But in right heart failure, this type of classification is not present. But this type of heart failure plays role in the development of the right ventricular dysfunction and right heart failure. So the principle of the diagnosis of the heart failure includes the steps approach, and all diagnostic steps are equally important to make the diagnosis. And first step is the medical diagnosis on the basis of the history, sign, and symptom. After clinical diagnosis, we have to confirm by the echocardiography and natriuretic peptide. After confirmation, we have to assess which group of the right ventricular failure is it. Pulmonary hypertension group 1 to 5. Next is the assessment of the etiology, because etiological diagnosis is the key point for the direction of the management of heart failure. And then we have to go for the risk stratification, and ultimately we have to work up for the targeted therapies of particular patient. So for the diagnosis of chronic right heart failure, ECG shows some changes that helps in diagnosis, and important findings are the right axis deviation, RS amplitude ratio is more than 1 in V1, R wave is more than 0.5 millivolt in V1, and P wave amplitude is more than 2.5 in lead 2 and more than 1.5 in lead V1. And some arrhythmias may be there, especially the atrial arrhythmias. And echocardiography is basically an important and very simple diagnostic tool to make the diagnosis. So what we can find in echocardiography in a patient with right ventricular dysfunction and failure, if we look, the RV wall thickness is more than 5 millimeter. Inferior vena cava diameter is more than 21 millimeter, and inspiratory collapse is less than 50%, and pericardial fluid collection may be present more than 5 millimeter in diastole, and tricuspid regurgitation peak velocity is more than 2.8 meter per second, and TAPSIM is less than 27. Dilatation of the right ventricle can be assessed by the right ventricular end-diastolic, and left ventricular end-diastolic ratio is more than 1. And RV basal diameter is more than 41 millimeter. These parameters, other is the right ventricular fractional area changes is less than 35%. Ventricular interdependence can be assessed by the septal shift and D-shaped LV, and systolic S velocity can be measured as well. Longitudinal strain of RV free wall is less than 20%, and right ventricular inbox of the myocardial performance is more than 0.5. However, three-dimensional echocardiography gives more information about the anatomy as well as the physiological changes. Some serum markers are important in diagnosis, that is the increased liver biochemistry. In heart failure, synthetic function of the liver is impaired, evidenced by the reduced albumin and elevated INR, but transaminase may be normal or minimally elevated. Abnormal renal function and NT-proBNP helps in the diagnosis as well as the management. And RNA sequencing may play a role as the RV-specific biomarker. So next investigation, important investigation, is the MRI, which is the gold standard non-invasive measurement of right ventricular volume, mass, ejection fraction, including the patient with congenital heart disease. So it can also diagnose the right ventricular dysfunction and failure, and can detect the changes and intermittent interventricular septal flattening, and also it can measure the cardiac output. Other investigation includes the CT scan, CTPA, radionuclide imaging, hemodynamic assessment of the right ventricular function, lung function test. Here, the overnight oximetry is useful when sleep breathing disorder is suspected, and ventilation perfusion scanning important to find out the underlying etiology. So when we go for the treatment of heart failure, we have some objective, and first objective is to improve the prognosis by reducing the mortality, and second objective is the morbidity, to relieve the symptom and sign and to improve the quality of the life. And next is the prevention, to prevent the myocardial damage and progression of the myocardial damage, and to make a favorable remodeling of the myocardium, and also to prevent the symptom development and fluid accumulation and repeated hospitalization. So management of the chronic right heart failure includes the non-pharmacologic intervention, pharmacologic treatment, device therapy, surgical management, and transplantation. These are the mode of treatment in chronic right heart failure. And non-pharmacologic intervention is very important, and it plays role for the prevention of the deterioration of the heart failure. Among these, education of the patient is very important. By explaining the nature of the disease, treatment, and self-help strategies, we can prepare the patient to maintain their lifestyle in such a way that their deterioration can be prevented by their lifestyle modification. Salt restriction is one of the important part here, the good general nutrition and weight reduction for the obesity. And salt restriction recommendation now about 2000 milligram salt per day is recommended by the most of the guidelines, though there are some variation in one or two guidelines. And smoking should be quitted. And exercise, symptom limited, moderate aerobic exercise is recommended for all patients of heart failure. And alcohol should moderation or elimination. But in case of alcohol-induced cardiomyopathy, it is the abstinence. There is no alternate option. But in case of chronic heart failure, we have to think about the vaccination for the influenza and pneumococcal disease. And diuretics, basically, what is the role? The goal of volume management in chronic right heart failure is to maintain sufficient preload for adequate filling, relieve more RV overload, ventricular interdependence, and congestion. And diuretic remains the mainstay of therapy to treat congestion. And intensity of the therapy depends on pathogenesis, severity of the disease, and presence of coexisting renal disease. And combination of the loop diuretics with thiazides may help to control the heart failure. And torsemide may be preferred in decompensated heart failure. In guideline, ACE inhibitor, ARB, and beta blocker is the class 1 recommendation. But in right failure, what is in chronic right heart failure? The patient with biventricular dysfunction, the guideline directed management of the heart failure is the standard practice. But in small scale, single center studies support the use of beta blocker, ACE inhibitor, and hydrolazine, though the results are inconsistent. At present, use of beta blocker, ACE inhibitor, ARB, are not recommended in patients with pulmonary hypertension unless it is associated with hypertension, coronary artery disease, or left heart failure. And prospective trials are not available on the role of MR antagonist, including the spironolactone in right heart failure caused by the pulmonary hypertension. And ARNI is a good drug in the management of the heart failure with reduced ejection fraction in NYSA class 2 and 3. It is definitely beneficial. It is also beneficial when to improve the right ventricular function. Right ventricular failure, it has got very good role in improvement of the right ventricular function. And digoxin is class 2B indication in the management of the heart failure. In a small studies, digoxin 5 to increase the cardiac output and right ventricular ejection fraction in patient with pulmonary hypertension and right ventricular dysfunction. But digoxin did not improve exercise capacity or right ventricular ejection fraction in patient with pulmonary hypertension and right ventricular dysfunction. A meta-analysis did not find any improvement in the right ventricular ejection fraction, exercise capacity, or improvement of the NYSA classification. So, clinical efficacy of digoxin remain unknown. The important drug is the pulmonary vasodilator therapy that to relieve the RV afterload has led to improvement in the symptom and outcome of the patient as well in group 1 patient with right heart failure. Rheosity guard is used in refractory group 4 disease to improve the exercise capacity. And mesitenan is another drug is under evaluation. And prostacyclin analog has long-term benefit on survival and functional capacity. Parenteral prostanoids remain the first-line therapy for the patient with advanced disease. Epoprostenol increases mortality in patients with left heart failure. And prostacyclin analog are not recommended to treat group 2 pulmonary hypertension. Phosphodiesterase inhibitor plays role in the heart failure in right side. Sometimes it play a role to manage the heart failure in left side as well. And it is associated with improvement in the pulmonary vascular remodeling, improvement in the RV contractility, anti-proliferative effect, and improvement of the exercise capacity, and reduce rate of clinical deterioration in patients in group 1 pulmonary hypertension. So their role in isolated right heart failure or pulmonary hypertension caused by the left heart disease remain uncertain. endothelin receptor antagonist is beneficial in group 1 patient that improves heart failure symptom, improves exercise capacity, improves hemodynamics, and prolongs time to clinical worsening. But we have to keep in mind that this group of patient needs liver function performance routinely. So mechanical circulatory support is reserved for the patient refractory to the optimal management and to bridge to recovery and to bridge the heart or heart-lung transplantation. It may be used destination therapy as well. But in case of acute heart failure, 42 to 75% may recover to allow the MCS device explantation. That is a good news. And mechanical circulatory support, if we look the isolated RV failure, pulmonary etiology for right heart failure and right heart failure associated with left heart failure, you will find that ECMO is the option, is applicable in 3 categories of the patient. So ECMO is an important tool. Unfortunately, till date, so far knowledge goes is not available in our country. We should go for that in future. So another option of the treatment is the palliative intervention that includes the balloon atrial septostomy, surgical right to left shunt, and surgical shunt placement between the left pulmonary artery and descending aorta. So balloon atrial septostomy is used as a bridge to lung transplantation, and it is a palliative measure in refractory pulmonary hypertension, and it can be used to unload the right ventricular volume. And balloon atrial septostomy is contraindicated in severe right heart failure with right atrial pressure more than 20 millimeter mercury, and saturation is less than 90 in room air, and pulmonary vascular index is more than 4,400 dynes. So surgical treatment is another treatment modalities that is reserved for the valvular involvement of the right side of the heart. And transplantation is for the advanced refractory chronic right heart failure after exclusion of all reversible causes and comorbid conditions. So transplantation should be considered in patients with pulmonary hypertension and chronic right heart failure where the right atrial pressure is more than 15 millimeter mercury and cardiac index is less than 2 liter. Patient with chronic right heart failure from severe pulmonary vascular disease, lung or double lung transplantation may be considered. So ladies and gentlemen, so I am going to conclude my lecture with few sentences. It is now well established that right ventricular dysfunction is highly prevalent and carries the poor prognostic significance in left heart failure. So prospective studies are urgently needed to clarify the management of the underlying right heart, remodeling and dysfunction, and to find out the effective treatment that improves the morbidity and mortality. We therefore greater focus on the open neglected right heart and for the introduction of standardized endpoint future studies, randomized trials on right heart disease and failure to meet the knowledge gap and focus the light on future management guideline so that we can recover from the dark zone of the right heart failure. Thank you very much. Thank you everyone for participation.
Thank you, sir. Thank you, Professor Abdul Qadir Akand, for your brilliant lecture on right heart failure. Thank you. Among the hospitalized patients in Bangladesh, around 73% of the patients are male patients. Only 27% are female patients. This doesn't mean that the incidence and prevalence of heart failure is less among the women in Bangladeshi population. Rather, the women patients with heart failure are using healthcare facilities less commonly. That is the reason behind this. You know very well the in Bangladesh, diabetes mellitus, metabolic syndrome, these are increasing in incidence and prevalence among the young patients. So many young women who are supposed to be protected in their reproductive life from ischemic heart disease are now suffering from early incidence of ischemic heart disease and ultimately ending up in heart failure. Besides this, 7.5% pregnancy in Bangladesh are suffering from hypertension. About 1 in 1,400 live births are suffering from pericardial cardiomyopathy. In fact, among the hospitalized patients, 1.4% of the patients suffer from heart failure, pericardial cardiomyopathy. Ladies and gentlemen, Dr. Abi Al-Hussaini, who is consultant cardiology in the cardiology department of Chelsea and Westminster Hospital, London, UK, she will be talking on heart failure in women. Dr. Abi Al-Hussaini, please.
Thank you. If you just bear with me, I'll share my slides.
Yes. Dr. Abi Al-Hussaini is a common face in Bangladesh. She visited Bangladesh on several occasions, and she's a brilliant cardiologist and speaker. Dr. Abi Al-Hussaini, please.
First of all, thank you very much for inviting me. And as you mentioned, you've kindly invited me to Bangladesh on a few occasions. So I'm delighted to be here virtually with colleagues and friends from Bangladesh. And I hope post-COVID, we all get to meet again. I've been promised to visit the tea farms in Bangladesh. So I look forward to that trip hopefully soon. I've been asked to talk about heart failure in women, and really I'm an interventionist, but I do find this concept of women being very different to men is a very interesting point of treatment and management in women that's kind of much delayed and also missed by many physicians. And I just wanted to bring this to the forum here for discussion and kind of tell you the story of what evidence I found when I looked into this. So hopefully what I could share with you, and thank you for sharing earlier some of the epidemiology you have in Bangladesh, the overall epidemiology of what I was able to find with regards to the concept of heart failure with women and men, what evidence and research we hold, and the disparities. Where is the disparity coming from? Is this biology? Is this bias? What's driving this? And how do we move forward? So I just wanted to start with a big statement, actually. So this is some of the UK data and some of the American data. Unfortunately, I couldn't quite find data in Bangladesh easily, but you kindly had shared some data with us just before I started. But there is a striking difference in the way we manage women and men. At least estimated 8,000 women die to due unequal heart attack care in the UK. And this is a healthcare system that's tax-based, that works on essentially equality and free treatment. So to have that disparity is very, very striking. So something is missing and something is being missed and mismanaged. We do know that heart failure currently affects over 2.5 million women, and is the leading reason for hospitalization, particularly women who are over the age of 65. So this disease increases in its prevalence, and data from the West and the developing world. So I suspect women in Bangladesh and Asia will be much younger at presentation, as you mentioned. Heart failure incidence triples for women. So post-menopause, we see this tripling effect of the heart failure incidence, particularly after the age of 65 and onwards. And heart failure with preserved ejection fraction is very common in women and highly missed. And again, women present with symptoms, but because their ejection fraction is normal, or they seek healthcare at a later point, or their presentation is atypical to what we are used to, this diagnosis is often missed. So we all know this, that the leading cause of death in the world is cardiovascular disease. In women, this is the same as well. So over the last 10 years, there has been a reshuffling of what diseases kill women in particular, and where we had breast cancer and communicable disease being the leading cause of death in Africa and in Asia, that has certainly changed, where now we're seeing cardiovascular disease being the biggest contributor of death in women. When we look at this data in high income and middle income, unfortunately, I couldn't find the data for low income, but it's very similar to the middle income countries, is that we find both in male and women, there is an increasing prevalence of cardiovascular disease. What we also do see is that there is a difference in women between the high income and middle income, where unfortunately in the middle income and the lower income country, the prevalence of cardiovascular disease is actually rising. So certainly that suggests the risk factor profile is slightly different, or if anything, the risk factor profile isn't being managed earlier. So as a result of it, there is more prevalence of cardiovascular disease that's now being seen, particularly in women in the kind of the middle income, lower income countries. And when we look at this data, if I can show you graph essentially A, which is at the top, you can see that when you look at the yellow and the green lines, which represent the high and middle income countries, and kind of the difference between women, you can see that kind of gap is closing, which suggests actually the kind of the incidence of cardiovascular disease is rapidly catching. And you can imagine the middle income or the lower income countries, the incidence of cardiovascular disease, which would be much higher if we were to extend that line. So certainly the epidemiology is all suggestive of there is a change in pattern where now we are seeing more patients, particularly women, are at risk of cardiovascular disease compared to the West. When we will look at one of the most prevalent risk factors, we see overall in all across the world and kind of middle lower income countries, that prevalence of diabetes has increased. I know I don't have an arrow here, but in South Asia, you can see more women in red have diabetes compared to men. So there is a change in percentage of the prevalence of diabetes, which could be one of the cardiovascular contributor to why we're seeing that difference. And if we look at that, when we look at patients who have got diabetes, particularly women, what we do see, so the women presented by the dark boxes here, we see overall they have a higher coronary mortality, myocardial infarction, and heart failure. So almost heart failure is twice as much in a woman who's diabetic than it is in men. So it suggests that even there is a disparity in the actual risk factors that we are seeing between men and women. But what does that mean? So what does it mean if I had diabetes as a female compared to a man? Well, what it does suggest that actually different risk factors have different way in men for women. For example, being overweight and smoking is a higher risk factor for developing cardiovascular disease or heart disease in women than it is for men. And when we further look at this, we kind of miss this concept of traditional and non-traditional risk factors, where we know that actually over the last 10 years, we've got to learn that chronic inflammatory disease is a big risk factor for cardiovascular disease. We know that metabolic syndromes, diabetes and obesity and renal syndromes play a big risk factor in both men and women. Retroviral disease, for example, is also another risk factor. But also on top of this, what we kind of miss in the non-traditional risk factors is the emerging risk factors, is that we are seeing more women present with gestational diabetes. We are seeing more women have hypertension during pregnancy. We are also seeing an increase in early menopause that's been mismanaged and misdiagnosed as well in women. And what does that overall mean when it comes to heart failure? Well, interestingly, women who have diabetes develop heart disease earlier than men are more likely to be at risk. Women with smoking are more likely to develop heart disease. Inflammatory heart disease is an important risk factor that's often missed, but it causes valvular heart disease. And again, this can present in women, causing heart failure. Hypertension is one of the leading causes of heart failure in the world, and particularly in women, which is mismanaged, but incredibly important. It's because what we don't manage very well is after menopause, there is a change in blood pressure and kind of endothelial function, and not many women have that addressed early on as they enter to menopause. So many of them are left undertreated for hypertension or diabetes or metabolic syndrome when there is a change of hormones. But what I do find very interesting, and I don't think we're very good at it in the UK, is that we are seeing many women with gestational diabetes, hypertension and preeclampsia. The minute the baby is born, the parameters return back to normal. There is absolutely no follow-up for these patients. And actually a high proportion of these patients go on to have cardiovascular disease and, more importantly, heart failure. And this could be something that could be addressed a lot earlier and better managed. So apart from all of these risk factors that I've just shared with you, that could be the driver for more heart failure in women, and the fact that more women are getting heart failure and also morbidity and mortality from it. Arrhythmias are common in women, particularly atrial fibrillation. Again, postmenopausally, we tend to see this. There are particular conditions like stress-induced cardiomyopathy, Takotsubo. We tend to see it though as benign. There is an association with increased risk of heart failure. Unfortunately, women still get breast cancer, and chemo and radiotherapy are big factors in causing heart failure in women. And also the concept of early menopause and multiparity, which seems to be quite missed in a lot of women who unfortunately present with heart failure later on in the future. I wanted to also go on from this point of risk factors is to share with you what do we know from trials so far. This was quite interesting, is that we take trials to kind of be our guidelines for management of women with any condition, but when overall in all kind of trials, women are underrepresented, but particularly in heart failure. If we look at all of the heart failure trials published and have gone on to be forming our guidelines and European guidelines, American guidelines, Asian guidelines, women are presented about 20 to 30% at best in these trials, which basically doesn't inform us very much about should we treat women the same as men? Do women have different physiological parameters that are not picked up? And actually, when they develop problems or endpoints, are these driven truly by the trial data, or is something else causing it? So certainly this is, this should be taken into account, and is something I think we need to kind of hopefully resolve in the future. Certainly this does indicate that there may be a unique pathophysiology and etiology that drives a difference in the cardiovascular physiology of patients, that there is a difference in drug pharmacokinetics that we may be missing because the trials don't actually give us a huge amount of information because women are underrepresented. And to this date, I haven't found a single trial that talks about heart failure only in women. So we still don't have a study that looks only at women to see the differences in age groups of women, or women and different hormonal therapies with heart failure. So all of that data is still lacking. I found the systematic review very interesting, and I just wanted to share the data with you because I think this is incredibly informative. This was a heart failure systematic review and meta-analysis that actually looked at low and middle income countries. And interestingly, it recruited patients from Southeast Asia, including India and Bangladesh, from the studies that it had looked at, though there was a lot of heterogeneity in these studies. Impressively, what I can show you is that you can see that in Southeast, this is men and women actually, impressively, that actually the patients in Southeast Asia tend to be younger than patients in America or Eastern Mediterranean. So there is a difference in earlier presentation in both men and women with heart failure that I think is very prevalent. Also interestingly, an underrepresentation of women. So across all studies, there was less women presented. And as I mentioned, there was a great heterogeneity seen in here in all the studies. Overall, the patients that were in these studies had a lower ejection fraction. You can see that the Southeast Asian had a much lower ejection fraction compared to other countries. And that's a very important key factor that I think it should be further discussed later on. But anyway, let's talk about the data. I've kind of put it in red so we can go straight to it. And this looks at how much beta blockers were used by region. And actually something like 34% of patients were treated with beta blockers. Now this is men and women. So we're currently under treating both genders with the actual therapy that works. When we looked at the angiotensin inhibitors, this was around 50%. So again, in both genders, it was much less than where it should be. And when we looked at the mineralocorticoid treatment, it's about 32% in the Southeastern Asia. So not only are we treating men and women lower, but it's likely if we look at women only, they probably will be much less treated with the appropriate pharmacotherapy. So this difference is not just biology, it's actually there tends to be some bias in the way we are managing patients. And hopefully I can share some data from Europe and the world about where we have actually seen this. So this is actually data that was published in the European Heart Journal, and this looked at kind of primary care setting. If I take your attention to the dashed lines, the kind of darker dashed lines are men and the lighter dashed lines are women, what we can see that less women are getting lipid lowering drugs in primary prevention. So they need it, but they don't get it. And certainly we're kind of seeing the peaks in age are much later. When we look at high blood pressure, we're seeing exactly the same. So less women are treated for high blood pressure in primary setting compared to men. So it happens at primary prevention in even just with patients having risk factors, they are not being managed appropriately. When we look at the the age-adjusted sex differences between patients, and this is kind of looking at different parts of the world, so Europe, Asia, and kind of the Middle East, all the data favors men completely. But if we break it down and look at Southeast Asia, again, there is much more favorable data towards men than women, which suggests for all factors like high cholesterol, diabetes, lifestyle management, obesity, women are not being appropriately managed and certainly are not getting the treatment they should be getting. When we look at patients who are diabetic, so just diabetic patients with risk factors. So again, we see the disparity between men and women. Again, men are getting better treatment and kind of controlling their risk factors much better compared to women. I think women only do much better in the kind of adequate physical activity when this data was looked at. So moving on, these are patients who've had a cardiac event and presented to hospital. The dark lines are men, the kind of the lighter lines are women. So in terms of having had an event, lipid-lowering drugs are less in women. Beta blockers given to women are much less again. Blood pressure medication, it kind of almost crosses the line, but again, men tend to have earlier treatment given to them. And similarly, for any anti-thrombotic treatment, we see the similar kind of trend of less women receiving treatment compared to men using the same guidelines that should be for men and women. When we look at out-of-hospital cardiac arrest, interestingly, more women actually have an initial rhythm for an out-of-hospital cardiac arrest. But when we look at men and women at discharge, we see actually less women are discharged from hospital, and we see actually probably higher mortality in women who have had an out-of-hospital cardiac arrest than men, assuming that they both have received the same treatment for that shockable rhythm at the same time. This data goes back to bigger studies looking at patients who've had, so this is a CRUSADE study that looked at some of the data with patients with coronary disease. And again, it showed that less women received aspirin, ACE inhibitors, or statin therapy after a cardiac event. We're looking at other data from a Danish study. Similar data was seen in terms of lipid-lowering drugs and anti-thrombotic treatment. And also all of these studies, when they looked at the medication, the analysis was done by medication, it found that there was a persistence in this gap between men and women. So this is not just biology. This actually indicates that there is a bias, that we as physicians, we're just not following guidelines as we should be, or making sure that women should receive the treatment that they need for particular condition, particularly cardiovascular disease, which is the driver for heart failure. I won't bore you too much on this, but overall what all of this data suggested is that amongst the bit where physicians were not meeting the need of the patient, that actually patients themselves as a result of it were paying less attention to their risk factors and to seeking help when they should seek help as a result of the physician guided management. I wanted to also bring to your attention some of the data I found on sex differences in advanced heart failure therapy. So this is some data that was published in Circulation on a paper looking at the difference in women and men with heart failure therapy. So this is patients receiving ICD therapy. And impressively, we could see that more men receive appropriate shock therapy than women, and certainly more women receive inappropriate shock therapy than men, though we use exactly the same guidelines to implant a heart failure device in a patient, in a female or a male, which suggests there is a difference in physiology that actually isn't seen with the trials, or certainly is something that is underestimated. When this data further explored patients with CRTD therapy, actually what was impressive is that women do better with the CRTD therapy compared to medical therapy with the same risk factor profile as men. So there is something physiologically that is driving that difference. and this is the so the end result of heart failure that being transplant therapy. Certainly internationally, there are less women receiving transplants. So I think in the world, the data looks at probably only 21% of women, patients who receive transplants are women. And it's unclear why this is, why are less women receiving transplant therapy? But certainly the data suggests that actually women do better after a transplant long term. And that's an important factor to consider, that there is something that suggests there is an importance of ensuring that these women receive this therapy and also they do much better with it. So I'm going to end by this point saying that heart failure is a very important cause of mortality and morbidity in women. And hopefully I've shown you some data to suggest that. We know that women, as they get older, menopause plays in, and there seems to be a change in risk factor profile that's underestimated, but not managed as well, and results in disease developing. And obviously there is a disparity across the globe of when that happens. Heart failure with preserved ejection fraction is much more common in women and unfortunately missed, but accounts for a lot of their symptoms. And overall, the guideline directed medical therapy isn't different in the way we deliver it, but clearly there is a physiological, biology and bias way of how we are delivering this, because we are seeing the disparity in patients. So I leave you with a take-home message that our trials are underrepresenting women at the moment, and certainly we need to investigate this further and look into different mechanisms and more appropriately treat our patients, particularly women, to ensure that they are protected and they have the same longevity and quality of life as our patients. Thank you.
Thank you, Dr. Abi Al-Hussaini. Thank you very much for a brilliant presentation. Ladies and gentlemen, the pharmacological treatment is changing the morbidity and mortality of heart failure patients over the last few decades. Still, there is difference in the pattern of pharmacological treatment among the different centers of our country, also in different countries of the world. When the heart failure patients are being treated by cardiologists or in tertiary care hospital or teaching hospitals, we are using more and more beta blocker, ACE inhibitor, ARB, ARNI, mineralocorticoid, MRA, all these drugs. But still, many of our physicians depend on diuretics and dioxin for treatment of heart failure. Not only because this is cheap and easily available for our patients, but also due to lack of knowledge and orientation of our physicians. Recently, FDA has approved SGLT2 inhibitors for the treatment of heart failure for both patients who are diabetic and for patients who are normoglycemic. Ladies and gentlemen, Professor Upendra Kaul, who doesn't need any introduction in our community, among the cardiologists, previously was Professor of Cardiology in All India Institute of Medical Science, now working as Chairman Cardiology and Dean Academic and Research, Batra Hospital Medical Research Center, New Delhi, India. He is the Joint Editor of Euro Intervention. He is also Course Director of AICT and India Live. Professor Upendra Kaul will be talking on journey of SGLT2 inhibitors from prevention to treatment of heart failure. Ladies and gentlemen, Professor Upendra Kaul. May I request Professor Upendra Kaul sir to deliver his lecture.
Thank you very much, Dr. Firozi, and I must at the outset pay my respects and gratitude to Dr. Abdul Qadir for including me in this wonderful program. I also enjoyed the talk of Ms. Hussaini from London, talking about the women and less evidence-based medicine treatment being given to the women, and that's a fact all around the world. Possibly that will be magnified in our part of the world. Let me share my slides. Are the slides visible?
Yes, sir.
Okay, good. So I'm going to talk about, as it has been introduced, about the journey of SGLT2 inhibitors, not only for prevention, but also treatment of heart failure. And in the treatment of heart failure, now we know that even non-diabetic patients are included. And there have been large number of studies on this, and the leader was empagliflozin, which in November 2015, first time a drug for the management of diabetes, which was undergoing FDA test to see whether it is safe enough for cardiovascular outcomes, was seen to be not only safe, but also producing better cardiovascular outcomes. This was followed about 2 years later by canagliflozin, and then in 2019, dapagliflozin. All the three molecules, I'm sure, are available in Bangladesh. They're all available in India. Now, coming to the study, the DECLARE, which is a very large study, and if you see, the EMPA-REG outcome study had 7,000 patients, whereas DECLARE had double the number of patients. And in EMPA, 100% of patients had atherosclerotic cardiovascular disease, whereas in DECLARE, about 60% of patients had only multiple risk factors like diabetes, hypertension, and others, and only 40% patients had established atherosclerotic cardiovascular disease. Now, this was a large study, as I already mentioned, about 17,000 patients who were randomized to either dapagliflozin or a placebo. And the primary safety endpoint was the composite of cardiovascular death, non-fatal MI or non-fatal stroke, and primary efficacy endpoint was MACE and composite of hospitalization for heart failure. And it also had secondary renal endpoints like the doubling of serum creatinine, decrease in the eGFR and other things. Now, DECLARE had multiple risk factor patients and also established heart failure patients. And as you can see, the age was around 64 years of age. Body mass index was on the higher side. They were all diabetics, HbA1c around 8%, eGFR around 85. That means a reasonably good renal function, and multiple risk factors patients were 60%. Now, this study showed that if you take the combined endpoint of hospitalization for heart failure and cardiovascular death, they were significantly reduced by 17% lower in the patients who were on dapagliflozin, whereas the major adverse cardiac events, although had some trend, but in comparison to empagliflozin, where there was a significant reduction in MACE, this was not significantly different, just a 7% reduction, which was not significant. The primary composite endpoint of the MACE, if you see, in patients who had myocardial infarction in the past, had a much more protection than if the patient did not have prior myocardial infarction, indicating that sicker patients had better benefit. And if you look at history of heart failure, whether the patient had heart failure or whether the patient had no heart failure, there was almost an equal benefit, but only about 10% of patients had heart failure. Look at the reduced ejection fraction, whether it had reduced ejection fraction and not a reduced ejection fraction, benefit was the same. Mind it, it was for prevention of heart failure. Now, if you look at heart failure and cardiovascular death, 38% reduction, heart failure, 36% reduction, cardiovascular death and all-cause mortality, a 41% reduction. Benefits of dapagliflozin were seen in both primary and secondary prevention. Now, if we combine and see all the studies, you would see that established atherosclerotic cardiovascular disease, empagliflozin very clearly had 35% lower chances of heart failure. Canvas had 31%, DECLARE had only 21%. Whereas major adverse cardiac events, you would see that there was about a significant difference of about 14% here versus about 18% here, but only 10% with declare. Multiple risk factors, there were no patients of multiple risk factors alone in EMPA, but Canvas, Declare, and all had shown a clinical benefit. Now, what are the possible mechanisms of this very beneficial effect? There are several, but if one has to sum up, number one, there is increase in the hematocrit. There is shifting to a more energy efficient fuel, that is the ketone bodies replace the glucose mechanism of giving the energy, and also there is reduction in the left ventricular mass. So these are the three very important mechanisms by which these work, and these mechanisms have been, known now after mechanistic studies. In the large studies, that was not one of the endpoints to see how it works. Now this brings us to DAPA heart failure study. Now, basically, the premise being, if a drug is reducing the chance of heart failure, how about if we give it in heart failure patients, will it improve the adverse outcomes of heart failure? Will it reduce heart failure hospitalization? Will it reduce mortality? Will it reduce all-cause death? That was the primary aim of this. And although DEPA study has come first, this is last EGFR more than 30 because these drugs act through the kidney and they have all stable heart failure, reduced ejection fraction. That means the results are not going to be applicable to class 4 patients who are admitted with acute decompensated heart failure. You have to stabilize them first. And over and above the evidence-based therapy consisting of diuretics, beta blockers, ACE inhibitors, ARBs, or ARNI, they were given dapagliflozin and also spironolactone versus a placebo. And the primary endpoint being time to first occurrence of any of the components of composite cardiovascular death or hospitalization for heart failure or an urgent heart failure visit, and several secondary endpoints which were a part of primary endpoint individually. Now, as you can see, 58% of the patients recruited did not have diabetes. Only 42% had diabetes. Once again, as Ms. Sani was talking about, females constituted only 1/4 of the patients. 3/4 were of males. And it had all races. And if you can look at 1/4 of the patients were Asians. By Asians, I mean South Asians and around the countries. And we participated from our center in India, has participated in this study. And Asia Pacific, once again, 23%, although Eastern Europe and Russia was the maximum percentage, about 34%. If you look at the ejection fraction, the mean ejection fraction is around 30%, and the median NT-proBNP is 1,400 and above. They're stable in blood pressure, ischemic etiology in about half of them, good EGFR, and once again, prior diagnosis of diabetes only in 42%. Now, if you look at the class, 68% of the patients were class 2 and 32 class 3, no class 4. One patient with class 4, that means nothing. Ejection fraction 31%. So, stable blood pressure, stable heart rate. And if you look at the quality of life index, that was again, about 68, which is, they had symptoms of heart failure. And these are the various quality life index of 6 minutes walk test, New York Heart Association classification, and NT-proBNP as a screening test. Now, this is very important that 93% of the patients were on diuretics as they are in the world, real world. ACE inhibitors, ARBs on ARNI, 93 to 94% of patients. And if you look at sacubitril valsartan combination, that is Vimada, in 11% of patients. Beta blockers, which is a must in the treatment of heart failure, 96% patients were on beta blockers. 71% patients were on aldosterone or eplerenone, and 26% of the patients already had a ICD implanted to prevent sudden death, because low ejection fraction is a definite indication for ICD, and CRT, that is biventricular pacing, in about 8% in both the arms. So equally distributed therapeutic modalities have been used. Now, if you look at the primary endpoint of cardiovascular death, heart failure, urgent heart failure admission, or a visit, you would see that there is a 26% relative risk reduction in the primary endpoint favoring dapagliflozin. And if you look at the composite of primary endpoints, you would see that there is a reduction of about 30% with dapagliflozin. If you look at cardiovascular death, there is an 18% relative risk reduction in cardiovascular death, which is a very important hard endpoint. And if you look at the subgroup analysis, the benefit was equal whether the patient is diabetic or non-diabetic. So we have a drug which can be used in heart failure irrespective of diabetes, although the SGLT2 therapy started as an anti-diabetic agent. Whether the patient was on ACE inhibitor, ARB, or ARNI, it did not make a difference. So a 25% relative risk reduction in both diabetics and non-diabetics. Now, if we look at cardiovascular death or heart failure hospitalization, once again, a 25% relative risk reduction. Total heart failure hospitalization and cardiovascular death, 25% relative risk reduction. And this is the cardiomyopathy questionnaire of the symptoms. There is a 6% change for the benefit in the symptom score in DAPA as compared to placebo, because placebos also work when symptoms are concerned. And more than 5-point improvement in the total symptom score, 58% of patients, more than 5% deterioration in 25 versus 33. That means there is much less deterioration in symptoms and much more improvement in the symptoms. Worsening renal function, which again is an issue when you use any drug, especially this group of agent, it happened in only 1.2% of patients versus 1.6% of patients on placebo. Hazard ratio of 71, that means about 30% better, sustained renal function. If you look at the hardest endpoint, that is all-cause death, whether the patient is dying of cardiovascular death less often, but if he's dying of something else, it counterbalances. Here, there's a 17% relative risk reduction of all-cause mortality, which I think is a very, very gratifying feature. And if you look at the NT-proBNP, which is an objective parameter of heart failure, in placebo, there's a 101% increase, whereas in dapagliflozin, there's a 196% reduction in NT-proBNP, confirming the heart failure biomarker reduction. Safety, adverse events, you would see absolutely safe. Any serious adverse event is, if at all, more common in the placebo, 42% versus 38%. Volume depletion, not a problem. Fractures, which have been associated with canagliflozin studies, not a problem. Major hypoglycemia, not a problem. Diabetic ketoacidosis, not a problem. And doubling of creatinine, once again, much lower. Renal adverse events, not different. Renal serious adverse events, more in placebo. And then if you look at all the beneficial effects of renal safety are pointing towards dapagliflozin. Genital infections, which is a issue with the SGLT2 inhibitors, once again, of course, these are selected patients in a randomized study where you don't take this patient, but if you take selected patients, there is no increase in the urinary tract infections or urosepsis or genital sepsis at all. If you look at patients exposed to at least one dose of the study drug, once again, you would see that genital infection is not a problem because this is considered to be a limitation of SGLT2 blockers. Gangrenes, 4-year gangrenes, once again, not a problem. Major hypoglycemia, not a problem. Ketoacidosis, not a problem. 4-year gangrenes, not a problem. And whether you look at diabetics, non-diabetics, no difference. So let me summarize what we talked about of dapagliflozin heart failure trial. This is the first heart failure study outcome trial with an SGLT2 inhibitor investigating the treatment of heart failure in adults with heart failure with reduced ejection fraction on top of standard of care therapy. That means over and above all the good things which we know about heart failure therapies, including mineraloreceptor, aldosterone antagonists. Dapagliflozin provided a very significant and clinically meaningful reduction in the risk of worsening heart failure events and cardiovascular death when compared to placebo, as well as improvement in the heart failure symptom when we add to standard therapy. The safety was very consistent and very well established safety profile of dapagliflozin, and the rate of discontinuation was low. And if we can, compare it with contest with other studies, DELIVER is the study which is going on for preserved ejection fraction. We don't know the results. And we know that FDA, US FDA has approved this drug for the management of heart failure. Before that, the Canadian Cardiology Society has done it. The Drug Controller of India has approved this drug on 3rd of July this year. That means about 10 days back, for the management of heart failure, and it is freely available anyway in our country. Thank you very much for a very patient hearing, and I would welcome any questions because I have another meeting in 10 minutes time. So any questions, most welcome.
Thank you, sir. Thank you, Professor Upendra Pal. Ladies and gentlemen, we are going through this COVID pandemic, and sir, Upendra Pal, sir, are you living within 10 minutes?
Yes, I am. I'm with you. Yes.
Can I ask a question?
Sure. Sure, sir.
During this COVID pandemic, among the anti-diabetic agents, 2 drugs has been to be taken with caution. One is metformin for fear of lactic acidosis in severe pneumonia, and another is SGLT2 inhibitors. What do you think of that?
Well, SGLT2 blockers, because they can produce volume depletion.
Yeah.
In a hypotensive patient, it could be a problem. But right now, there is a large study going on COVID patients with cardiac involvement, in which dapagliflozin is being tried, and we'll know the benefits of it. Maybe it benefits, but we don't have any data in these particular patients. And we know that DPP4 inhibitors are safe in the patients of diabetes who get into this unfortunate issue of COVID. Insulin, of course, is the drug of choice in all the hospitalized patients, in all the patients on ventilators, in all the patients on, non-invasive ventilation.
But it's always welcome oral medicine because that reduces the exposure of the nurses and doctors to the patients. You don't have to give an injection.
That's right.
Yeah.
Hello, sir. I'm Dr. Zaman.
Sure.
Yeah. Sir, I have got one. I have got one question to you.
Yes.
So, can I the DAPA heart failure that shows that it can be used more both in diabetic and non-diabetic patient.
Yes.
But at least 55% patient was non-diabetic in that
No, no, no.
study.
52% patients were non-diabetics.
Yeah, that's it.
48 were diabetics.
That means that it can be safe to be given in both diabetic and non-diabetic patient.
Yes,
But
it is safe.
we are a little bit scared about the use of anti-diabetic patient in heart failure patient, because it was started as an anti-diabetic.
Yes.
But if we give to a heart failure patient without having diabetes, so there is a common apprehension about the patient and patient attendant, and also some physician, that by mistake maybe this drug has been given to him. He's not diabetic. Is it a problem in your clinical practice?
No, I think it's a matter of counseling. It's a matter of counseling because anything new which comes and it will be surprising that how come this thing. But when empagliflozin came,
Yeah.
now I think 6 years ago, it was an anti-diabetic drug, and suddenly it showed that it's improving the outcomes, and it's excreting sugar through urine, and all of us were being taught to check urine by uristicks. And now any patient on SGLT2 blocker will be throwing sugar. So these are concepts
Yeah.
which have changed
So
with time.
same with
Yes.
your tadalafil or these are
Yes.
the drug commonly
Yes,
given
yes.
for some purpose, but
That's right.
it helps to improve the patient with heart failure. So
Absolutely.
initially
Pulmonary
there was
hypertension, and yes,
some
yes.
taboo not to use this.
That's right. These are
That's a
some
good thing
things
to
which
counsel
come
the
and we have
patient.
to teach. I think we have to have CMEs with general practitioners. We have to, teach the doctors first because it is an individual doctor who will convince the person.
But definitely it will not produce any hypotensive, hypoglycemic
One has
event.
to be little careful because many of the heart failure patients are on high dose of diuretics. So
Yeah.
we should try and reduce the dose of diuretics
Yeah, there is a
because that
diuresis,
can produce hypovolemia.
And what's the dose
but
that
there
can
is
be
little
given
chance of
safely?
hypoglycemia. What
Yes.
about the chances of hypoglycemia?
Hypoglycemia, as was seen in this study, was
They have not shown.
not seen. It was a supervised study, and at best, the HbA1c reduction with the SGLT2 is 0.87. So it should not produce hypoglycemia. The dosage which is recommended, which was used in this, was 10 milligrams. It is
Yeah.
available as 5 and 10, but in a borderline patient with pressures around 100, which very often patients have, you start with 5, look for a few days, and then go to 10.
And in our country, I think we have got two strengths.
10 and
One
25.
is
10 and
10
25.
and 25.
Okay, 10 and 25. Then 10 is the dose. 10 is the dose. Empagliflozin is 10 and 25. But empagliflozin has still not the Emperor trial. We still have to await. I'm sure. Hopefully, it should be positive. But till that time, I think we should be using dapagliflozin because it is the only drug which has been shown. And we know evidence-based medicine is evidence-based medicine. We'll be very happy if HEPA comes positive because then we know it is the same. But let me tell you that all SGLT2 inhibitors are not the same. Now, a new one which has come, ertuglutide, which was released only about 10 days back, and it came in the American ADA conference. It showed that yes, it also reduced heart failure incidence, and it had the patient population was exactly the same as for EMPA-REG, 100% patients with cardiovascular disease, and it did not show even 1% reduction in MACE. So the commonality ended at reducing the heart failure, but the other benefits were not being seen. So we have to study because we are not going to find head-to-head trials between two. EMPA is not going to have a trial with DEPA. DEPA is not going to have a trial with CANA because commercial interest and also very large number of patients required for similar molecule drugs.
So if there is no other question, then any question?
Yes, please go ahead. Can't hear you. Unmute yourself. Unmute.
Professor Atharai, sir, you can ask your question.
Yes.
Unmute and ask the question.
Yes.
Now,
Yes.
can you hear me?
Yes, I can.
Yes, sir. Sir, I have just asked a question, sir. Sir, is there any evidence that we can combine ARNI and SGL2 together when the heart failure management? Is there any that is if ARNI cannot do?
Yeah, very well, very good question. But in the DAPA heart failure study, 11% patients were on ARNI. 11%. ACE inhibitor, ARNI, and ARBs combined were 92%. But if you look at ARNI alone, because they're still not being prescribed so often as ACE inhibitors, but they were 11%, and the benefit was same whether the patient was on ARNI, ARB, or ACE inhibitor. So you can.
Thank you, sir.
So if no more question is there, then I, on behalf of the Department of Cardiology, I express my heartfelt thanks to eminent cardiologist, real teacher and researcher, Professor Upendra Kaul. I know him since 1998 when I visited his center as a trainee in interventional cardiology. So once again, his presence glorified our program. There is no shadow of doubt. And he is a very known figure in Bangladesh. So from the core of my heart, I express my thankful gratitude to you, sir. Thank you very much. Thank you, sir.
Thank you very much, and may Allah bless all of you. Thank you. Assalamu alaikum.
Thank you, sir.
Thank you,
Thank
sir.
you, Professor. Thank you, sir. Ladies and gentlemen, we are going through COVID pandemic. In fact, the COVID-19 has got more mortality and morbidity among the heart failure patients. Not only that, this SARS-CoV-2 virus is creating different cardiovascular conditions, which are also creating heart failure. So Dr. Resham Barua, who is the consultant cardiologist, Chelsea and Westminster Hospital, Imperial College London. She is the technical director, NICE guideline for heart failure management. She'll be talking on management of heart failure in COVID pandemic. May I request Dr. Resham Barua to deliver her speech.
Hello, thank you all for having me. Can I just check that you can hear me?
Yes, yes, ma'am. You are clear. You're great.
And hopefully you'll be able to see my slides in a moment. So I tried to put together a presentation that I hope would be pertinent to what we are all going through at the moment, and was triggered by numerous conversations that we've been having with our friends and colleagues in Bangladesh, and which Dr. Monjor has been facilitating. So again, thank you very much for inviting me to speak, and it's a great privilege and pleasure to be able to take part in this webinar.
You are welcome, madam. Yes, yes, ma'am. Go on, please.
Great. So what I hope to talk to you today is a little bit about risk, the risk of heart failure, but also the risk of COVID, and the risk that we now face a new situation where we are, where our patients now pose a risk to us. And we pose a risk to our patients. So perhaps in trying to manage their heart failure, we may expose them to COVID, or they may expose us to COVID. So this is hopefully just a talk thinking about some of the processes that we should think about, and how we can safely diagnose people with heart failure, and how we can best treat and manage our patients, and particularly those patients with heart failure with reduced ejection fraction, because as we've already heard today, that's where most of the evidence lies. So I do not need to tell this esteemed audience about how heart failure is the most malignant disease in cardiology. If you were to be admitted to an NHS hospital with an ST elevation MI in the UK, then your 1-year mortality is approximately 7%. If we contrast that with a heart failure admission to a UK hospital, the 1-year mortality is actually closer to 28% or 30%. And so we really are dealing with an incredibly malignant disease here. And that is true internationally. So that is true in the United States. And whilst these data are old, I think they still hold true.
Ma'am, can you share your screen?
Oh, I'm
Can't see your
sorry.
screen.
I'm sorry. I thought I was. I do apologize.
It's okay.
Are you able to see now?
Yes, you have to go for slideshow.
Yeah. I'm sorry.
That's fine. Now it's
Go
visible. Yes.
back. You can
It's
see
okay.
now.
Yes, ma'am.
So apologies. So as I was saying, and as you are all well aware, the most malignant disease in cardiology and one of the most malignant diseases in medicine. And these are the UK data. It is common. The prevalence is increasing as the incidence increases. And for any healthcare system, the impact is huge, particularly in terms of budget. So it is the most expensive condition that we treat in the UK to the NHS, and that is in part because it costs so many bed days. So it's the hospitalizations that cost the money. And this is not just true of the UK. So cardiovascular disease is now the most common problem in Bangladesh and is increasing in incidence. And all of these slides that I've shown you are slides that I've shown at presentations for many years and has held true for a long time. But now we're faced with a slightly different problem, which is the COVID issue. But what were we doing pre-COVID? So in the UK, we have a very formalized, standardized way of making the diagnosis of heart failure. And this is based on the NICE guidance. So NICE is our National Institution for Clinical Excellence, and they look at both the efficacy of tests and medications and interventions, but also the cost effectiveness, because everything has a resource implication. And so the NICE guidance, which looked at chronic heart failure in 2018, really used natriuretic peptides as the gateway to diagnosis for heart failure. And the reason why it became cost effective in the UK to use natriuretic peptides was as a gatekeeper, because for us, the cost of a natriuretic peptide is around, it's between about 20 and 35 pounds, which is quite expensive for a test. However, it cuts down significantly on the number of people that need echocardiography. And in the UK, we are limited by the number of people we have that can perform the echocardiography. So our resources are limited by the number of sonographers that we have. And actually, when you plow through the data about the use of NT-proBNP, it was actually the identification of those patients with heart failure with reduced ejection fraction that made it a worthwhile pursuit. So the reason why we are ECHO in the first place is to identify that cohort with heart failure with reduced ejection fraction, because they are the cohort for whom we can change prognosis. So the NICE guidelines say you should do NT-proBNP, and if that is raised, you should do echocardiography. And depending on how raised it is, that will determine how quickly you should do echocardiography, because we are looking to identify those patients either with reversible causes in the form of valvular disease, or those patients with heart failure reduced ejection fraction. And the NICE guidance is very clear about what treatments, what disease modifying agents we should be using for our heart failure patients. So if I talk you through the algorithm, for those with heart failure and preserved ejection fraction, there were no prognostic medications that were determined to be efficacious, and therefore what the NICE guidance says is to treat the comorbid conditions such as the diabetes, such as the hypertension, and to look at exercise programs But all the drug therapy is on this side of the algorithm for the heart failure with reduced ejection fraction patients. And for the NICE guidance, they're really talking about an ejection fraction of less than 40% because that incorporates most of the trial data. And first line for all these patients with heart failure reduced ejection fraction were, according to NICE, are ACE inhibitors, beta blockers, and MRA if symptomatic, so spironolactone or eplerenone. And then for NICE, the position for ARNI, which we've heard about, is down here, which is if you have been stable on an ACE or an ARB for a month or longer and continue to have symptoms and have an ejection fraction of less than 35% in the UK, you then qualify for an ARNI. And the other specialist treatments include ivabradine, nitrates and hydralazine, digoxin, and device therapy. And we know that in this most malignant of diseases, if you take the combination of ACE inhibitor, beta blocker, and MRA, particularly at optimal dose, there is the potential to triple life expectancy. So we take the most malignant disease in cardiology and we have the ability with simple available drugs to triple life expectancy. And we've heard a lot about ARNIs already today and the paradigm study. And to say that paradigm as well as DAPA-HF did have some patients from Asia, so they were Indian patients, but there was representation from Asian patients. And when we do a network meta-analysis of our heart failure with reduced ejection fraction medications, we see that the optimal combination of medications. So if you or I, unfortunately, were to develop heart failure with reduced ejection fraction, what is it we would want? Well, we'd want an ARNI rather than an ACE or an ARB, a beta blocker and an MRA, and we can have a profound effect on both mortality and hospitalization. And following on from the last talk, I now think that we are entering the era of no longer talking about triple therapy in heart failure, but rather quadruple therapy. And as a heart failure physician who knows very little about diabetes, for me, SGLT2 inhibitors are heart failure medications first and foremost. Unfortunately, in the UK, I cannot prescribe them to patients who do not have diabetes, but I believe the evidence is there from DAPA-HF for the use of the SGLT2s in patients who do not have diabetes. So the inclusion criteria for DAPA-HF, as we just heard, was symptomatic heart failure. This was a heart failure trial, not a diabetes trial like the EMPA-REG trial. And of note, the exclusion criteria was an EGFR of less than 30. In the UK, we cannot give SGLT2s for EGFR less than 60, but DAPA-HF demonstrated that it is safe to give in patients with EGFR down to or above 30. So we've just far more eloquent. I can describe all about the DAPA-HF trials, carry on. In my experience, these are well-tolerated medications. Patients like them because of the weight loss, though often the weight loss is not profound. But there are issues with urinary tract infections, particularly in real life, and patients do need to be warned about that. But what's very key, I think, particularly in the COVID era, is this volume status issue. So in the UK, we have this terminology around patient education called sick day rules. And we would say that patients who have any sort of diarrheal illness or illness that could lead to hypovolemia, including fever, which is a key point in COVID, should hold their ACE inhibitor, their ARB, their ARNI, potentially their diuretics, their SGLT2 inhibitors, until that illness has resolved. And that's a really key message that needs to come out, because the cases of euglycemic ketoacidosis that we've seen in our centres have been related to patients continuing to take their SGLT2s when they've had concomitant other illnesses. Okay, so how does all this sit, which, you know, we're all very familiar with the evidence base for the heart failure with reduced ejection fraction disease modifying agents. How does that sit in COVID-19, and what are we doing differently, and how are we going to manage our patients? So these are the data about the mortality of from COVID-19 in the UK, and here we have the Bangladeshi curve, and I find it very interesting that you have a population double the size of ours, but your number of recorded deaths is at the moment far fewer, though I'm feeling less optimistic when I look at the shape of your curve, but perhaps you will tell me more about that later. And those deaths in the UK are excess mortality. So these are not deaths that we would expect to occur anyway. There has been a substantial excess mortality, unfortunately, from COVID-19, and it has changed the way that we have practiced, and it is changing the way that we are managing our heart failure patients, because we have to be pragmatic. Our resources at the moment are far more limited, and we have to act in a way that is safe and responsible to our patients and our team. So fundamentally, I showed you what NICE says we should be doing under normal circumstances. Under normal circumstances, patients would normally present to their primary care physician with symptoms of breathlessness, fatigue, swelling, and their GP should be sending them for a BNP test. And if that is raised, then they should be getting an echocardiogram in a timely fashion. So in terms of those echocardiograms and providing that happens at our centre, at our hospital, and we need to decide, is it appropriate and necessary to do that echo scan? So where we have a BNP, particularly if it's markedly raised, that may push us towards doing an echo scan. If we have a BNP that is marginal, then we may think that actually we can go without an echo scan for that patient. So what we really need to decipher is, what is the clinical need for that patient to get that echo scan, and what is the risk to the patient, and what is the risk to us? And this is going to be on a patient by patient basis. We need to consider how vulnerable the patient is to both spreading the disease, but also contracting the disease, how likely they are to have heart failure. So this is very much Bayesian principles of pre-test probability. What resources do we have available? And are we likely to get heart failure with reduced ejection fraction where we know we can make a difference? So the risk factors for COVID, as I'm sure we are all aware, people the elderly do worse if they contract COVID. And in the UK is a disease of the elderly. Our mean age of presentation is 78. Patients who have known cardiovascular disease are more susceptible, or certainly more susceptible to a worse outcome with COVID. And obviously, if someone has had ischemic heart disease, they are more likely to develop heart failure. Diabetes, again, this is a risk factor for both diseases, both for COVID and for heart failure. Chronic respiratory disease, in the UK, there is a big overlap between populations who have chronic obstructive pulmonary disease and those who have heart failure. Hypertension has been the big story of COVID. Patients with hypertension and obesity, I should say as well, have been very prone to COVID and to worse outcomes, and this may be to do with the ACE2 receptor. but obviously heart failure is a risk factor for both HFrEF and HFpEF. So here we see that the cumulative incidence of heart failure increases as people are more hypertensive. Sorry, I should say the yellow and the blue graphs are for COVID. The red and the blood pressure graph are for heart failure. Cancer is a risk factor for COVID, but obviously age is related to cancer risk. Obesity is a risk factor for COVID, and here we go, obesity is a risk factor for heart failure. So we're looking at very closely aligned populations, and people who are overloaded with heart failure will also have a cough. So some of the symptoms also align. And we've talked about gender today. The male gender is much more of a risk factor for COVID and a worse outcome with COVID. And as we've already seen, we seem to see more heart failure patients with who are male, but that may be due to inherent biases. So we need to screen our patients before we bring them in for these echo scans. And I'm not saying that we shouldn't be diagnosing the heart failure. I'm saying the opposite, because of course, I've shown you this is a high mortality condition, which we can do something about. But we need to make sure that we are not bringing patients who have symptoms of COVID into our department, or patients who've been in contact with someone with symptoms. And we need to decide, is this a diagnosis worth doing? Are we going to be able to manage the heart failure? And in many healthcare conditions, in many places, that will depend on the patient themselves. Are they going to take the ARNI? Are they going to take the beta blocker? Are they going to get a device? How are they going to get to the hospital? And in terms of patients who are established on medications and who need up titrations, how many times are we going to keep bringing them back for monitoring and to up titrate them? And I think it's often worth being explicit with patients and asking them explicitly whether they are currently being tested or anyone has considered that they may have COVID. If the decision is to go ahead with the echo scan, we need to safest way possible. So we need to look at the flows through our departments. Are we using separate entrances and exits for people? How do we minimize the amount of contact people are having within the hospital? How much spread we're getting within the hospital? So we're putting masks on every single person that enters the hospital. In the UK, we're not allowing relatives in. It's just the patient themselves. And we need to just double check that they have not had any symptoms that could be COVID when they do arrive. And we're doing temperature checks, and we're also doing the COVID tests on people. Our staff are extremely anxious at the moment. I know in Bangladesh, you've had a lot of deaths of healthcare workers, and this is absolutely tragic. So we have a responsibility to protect ourselves and our teams, because that is how we are going to get the best outcomes for our patients. So at the very least, when doing an echo scan, we're saying that you should have eye protection, the fluid resistant mask, an apron and gloves, but actually ideally you have the full visor and the surgical gown and 2 pairs of gloves, because for anyone who has performed echo, you can be sat there next to the patient, breathing in the air that they're exhaling for a good 20-30 minutes. So that was a little bit of a romp through about what we're doing. In terms of the medications, we know that ARNIs are safe in acute heart failure. The experience with ARNIs is that they can cause quite a lot of volume depletion, but they're profound. They do lead to a fall in blood pressure. So in my experience, the patients who do best with ARNIs are those who are NYHA class 2, but it is safe to start it in an acute setting. And if it were you or I who have heart failure, you would want an ARNI. So it's important to try and get people on the best medications as quickly as possible. As I've alluded to, because of COVID, we may try and reduce the number of steps of titration to optimal doses. So there is a balance here between optimizing and being pragmatic and not bringing back people too much, because every time we make a step change in medications, we need to recheck renal function. And what we're trying to do is minimize contacts to the absolute necessary. So we need to think about the individual patient. What is their risk of heart failure? And in particular, what's their likelihood of having heart failure reduced ejection fraction? What risk is the patient posing to us, to the healthcare workers, to the team? And in performing a diagnostic test, in performing echocardiography, what we don't want to do is expose patients to a potentially life-threatening disease in the form of COVID. So I think on an institution by institution basis, we need to be thinking about how we most safely manage the patients with heart failure and the wider department, and how we get them on the best medications as quickly as possible. But also for those patients who have symptoms of COVID, particularly if they have a prolonged fever, who are already on medications, we need to be very careful about telling them to hold those medications that can lead to hypovolemia. So I hope you could see all that and hear me, and thank you very much for having me. I think at the time of COVID, it's all the more pertinent to go back to absolute first principles of doing the basics well, and always to keep what Hippocrates said at heart, which is that we have a responsibility to first do no harm.
Thank you, Dr. Rishambarwa. It was a brilliant talk. It was a time-demanding talk. In fact, our cardiologists are looking for these sort of suggestions regarding the management of heart failure in COVID and pandemic era. We have got Professor Abdul Wadud Chaudhary sir with us. He's a great clinical cardiologist and professor of cardiology and head of the department of Dhaka Medical College. Sir, would you please tell us your experience regarding heart failure in COVID era among the COVID patients?
Well, to tell you the truth, in this era of COVID-19 pandemic, we are dealing patients in Dhaka Medical College, but only the inpatients, because the outpatients, they are basically getting their initial diagnosis and being referred to other hospitals. All the non-COVID patients, they are not getting in there. And the patients with heart failure, those are being admitted. It creates a little bit of a problem because the shortness of breath they're suffering from, is it due to heart failure or its exacerbation or due to the pneumonia itself? And sometimes we have to use the CT scan. Antidepressant we cannot do more often, but we can do the CT scan to have an idea what I can do, because I cannot check the patient properly to see whether the patient have raised at the base of the lungs. I cannot do that properly because of the chance of exposure. So we have to resort to the patient's what he is feeling, he or she is feeling, what she's telling, what the ECG is saying, and what the investigation like a chest X-ray or ECG is telling us. And that creates a great difference. And we have to do some compromise, keep oxygen as well, see the response. If he's not responding, then add a diuretic, taking care that the patient do not get hypovolemic. And that's one thing, because if you are making the patient hypovolemic, you are increasing the hematocrit, making hemoconcentration, the chance of thrombosis is much more. And that's the problem we're facing, and we are taking all these points into consideration and taking a middle road of everything.
Thank you, sir. May I request Professor M. Athar Ali sir to give his opinion. Professor Athar Ali sir is the leading electrophysiologist of our country, and he's doing the different devices like ICD and CRT in our country. Though the number is very low in our country, it is hardly 150 to 200 devices per year when we have got more than 1 million heart failure patients. Sir, would you please tell us about your experience regarding these device therapies and how can we make it more available to our patients?
So thank you, Dr. Firoz. And finally, I want to congratulate all the speakers, particularly not only Dr. Resham Borua. I'm happy to congratulate you for a brilliant and nice and very informative lecture. But I must also mention the name of Professor Abdul Qadir Akhando. Particularly, he has nicely described. I have never seen such a type of lecture on the right heart failure today. It is a great lecture I have seen today. That is particularly, I know about the heart failure, but particularly regarding the right heart failure. And also Abi Al Hussein. I have got question for Abi Al Hussein, but still I want to ask that is Resham Borua. That is in our experience, I deal with still I work in a tertiary care hospital. We have got the well-developed cardiovascular system. There are the not only it is the heart failure. We have got many of the patients. I don't know whether these are the coincidence or this is the real etiological correlation. We don't know. We have got some of the patient that is they presented with the complete heart block. This patient has got the COVID positive. I don't know which one is the first. Complete heart block. We have got some of the acute coronary syndrome. The patient underwent the angiogram. COVID positive. Coronaries are normal. There are some reports that the patient got the sudden cardiac death, and the patient was the COVID positive. So there are the varieties of presentation. In also, we have got some of the, my colleague is a pediatric cardiologist. She told that she has got some patient. He has got that is a coronary vasculitis, like the Kawasaki's disease. So this is the diverse presentations of the COVID patients. But what we learned from you, particularly regarding the heart failure in the COVID era, that is outstanding, and definitely that enriched my knowledge, particularly for regarding of this patient. But we have seen that is these are the, and particularly what Dr. Firoz has told, not relating to the COVID, as a whole heart failure, there is a huge number of the patients. The Bangladeshi population is nearly that is 50% of the US population. The percentage of the population, that is 30 crore in US, 16 crore in Bangladesh, 50%. But the number of the device utilization is just less than 1% of the what is used in the United States. So this is the difference. That is rate of utilization of the device therapy. Particularly, there are many limitations, and the patient does not get access to this. There are many of the patients, but they does not get access to these kinds of the therapy. So this is not the forum to discuss all the issues today. But I want to congratulate you for your fine discussion about the heart failure. And if you want, you can comment. Is there any correlation? Can you explain any pathophysiological mechanism that is the coronary, that is the acute conduction system disorder in case of the COVID? Dr. Borua.
Yeah, so we have seen it as well. And in particular, we've seen it on the intensive care unit. So people who seem to have extremely severe COVID requiring intubation and ventilation do seem to get bradycardias, arrhythmias, and complete heart block. There seems to be sort of, I think at the beginning of this process, we were expecting to see more myocarditis, COVID myocarditis than we've seen. What I think is happening is that we're getting a sort of stress cardiomyopathy and the effects of this catecholamine response. But like you, we're seeing everything. We're seeing thromboses everywhere, including in the coronary arteries. We're seeing, I think, inflammation within the heart, but not on what my colleagues in northern Italy are saying is that when they do the post-mortem, they're not finding the viral PCR within the myocardium. So it's a very odd picture, but we are seeing this complete heart block. And actually, I think by the time patients are getting the arrhythmias, the prognosis is really very poor.
Can I add something regarding that?
Welcome.
I had to do a pacemaker implant yesterday. That's a COVID patient. He was doing well. He had some bradycardia, some bundle branch block, doing well and preparing for going home. Then he suddenly developed severe bradycardia, heart rate around 20, has to be put on an emergency temporary pacemaker, waited for more than 2 weeks whether he revert or not. He doesn't. the rate remains very low, around 25 heartbeats per minute when we lower the TPM rate. So I have to put the pacemaker yesterday. And this is very terrible. Some of the patients we are seeing, before they are getting very worse, they develop bradycardia, and then they suddenly develop very severe symptoms. And apparently they were getting well from the pneumonia side, and then they are getting very bad again. And that's the point. Whenever they are getting bradycardia, I tell my doctors, be aware, this patient is going to crash if you are not taking care. Be more aggressive in that.
Thank you, sir. Thank you, Dr. Abdul Wadud Chaudhary. May I request Dr. N.A.M. Mominuzzaman sir to say a few words about this. Mominuzzaman sir is the leading interventional cardiologist of Bangladesh, and he's working in United Hospital. He's also conducting a heart failure clinic in United Hospital. Sir,
thank you.
Sir, would you please
Yeah,
tell us about
it's
your
a wonderful-
experience in heart failure clinic?
It's a wonderful program organized by Salimullah Medical College, especially Abdul Qadir Akand, and also a very nice deliberation on this specifically heart failure in the era of COVID-19 by three international faculties, Professor Upinder Kaul, Professor Abiel Husseini, and Resham Barua. Excellent. Especially, I have to say the many things actually we underestimate the situation of heart failure in and all over the world, not only in Bangladesh. Especially right heart failure, the way Dr.
Professor Kadir
given, really it's a opening of eyes to a most neglected part of heart failure is the right heart failure. Actually, we commonly feel that it's a secondary to left heart failure. Commonly, we are practicing right heart failure like this, but there are so many ways that can be causing this heart failure. After just listening the lecture by Dr. Akand, it's really impressive. And yeah, Professor Upandragul, as usual, his lecture was excellent because this is a new dimension in the treatment of heart failure. Probably it will come in the next guideline. Two more drugs will come. One is SGLT2, and other one is the that is we call it glutyl cyclase stimulator. That is very easy. When a new drug is coming, that will help to improve the treatment of heart failure. In general, all the heart disease patients end up with heart failure. So it's something like no way. Whatever we are treating the patient by angioplasty or by bypass surgery, because of the aging process, the number of heart failure patients is increasing day by day, and it is most underestimated the problem in the society, including the Western country. We are talking about cancer and many deadly disease, but none of them really supersede the heart failure. It is more than 48% patient, 5 years mortality. It's a huge number. So I think it's a time to mitigate this problem. Moreover, the Asian burden is extra burden because of their younger age, there are more mortality and less amount of the excellent medication are underutilized, like ARNI, aldosterone antagonist. So these are the issues should be targeted to tackle the heart failure. To me, I think it is not the single man show. It's an integrated program in a more organized form. Not that the chamber, it's a more organized form, comprises a cardiologist, a specialist, especially on clinical cardiology, a dedicated nurse, a counselor, then a psychiatrist. So all this can handle this neglected group of patient, because once the patient, a heart failure patient in a family, really he's a neglected one because he always depend on somebody. He cannot go to the hospital alone. He needs somebody, especially the hospital more neglected than male. So these are the issues needs to be addressed specifically. In my hospital, I am running the clinic, heart failure clinic for last 2 years, and there's a unique database clinic. Medtronic has helped us to provide me a software. We call it Smiling Heart. There's a unique part is this. Nowadays, we have seen the difference between the treatment what we are giving now and the treatment given earlier. Every day morning, my counselor, once he open up the laptop or the computer, he will find a number of patient contact number waiting to be just make a phone call. It is a computer generated, software generated number of patient needs to be contact over phone every day, depend on his previous clinical situation. Like if the patient has class 3, he will be informed early, say a week or two. So this way, we have seen an excellent outcome. In a sense, the number of hospital admission and number of serious acute decompensation or previously compensated is number has reduced, because every day, at least once in a week, the serious patient will be get a phone call from my counselor. How are you? What is your body weight? Are you taking the medicine regularly? So these are certain things actually he's been asked. So they are constantly attached with the medication. That is the one way it reduces the number of rehospitalization. I think not the prescription will help them to treat this patient. It needs integrated approach, and it doesn't need any special, super special cardiologist. Simple a case manager, we call the case manager. She is enough, especially these are paramedics. I recruit a paramedics to handle this patient. I don't recruit a postgraduate doctor. A paramedics who is authorized to write even prescription. He'll just make a phone call. How are you? What is your body weight? Are you taking the drug? Is there any side effect? So either way, and the patient also give you a phone call. Today I'm getting more weight. Okay, increase the diuretics. Okay, I'm not getting, my pressure is low. Okay, reduce the dose of ACE inhibitor or ARB or ARNI. So these way they can titrate the medicine, keeping them at home. So I think everybody should think in a way to support this neglected group of what Resham says, the malignant cardiovascular disease, in an integrated approach to at least improve the little bit quality of life. That is a few things I can say. Thank you very much once again
Thank you, sir.
for this wonderful program. Thank you.
Thank you, sir. May I request Professor Sajal Krishna Banerjee, sir, to say a few words regarding this. He is also the Dean of Medicine Faculty, Bangabandhu Sheikh Mujib Medical University. Professor Sajal Banerjee, sir.
Thank you. Thank you, Dr. Firoz. First of all, I must give thanks to Professor Abdul Qadir Akand for arranging such an exceptional symposium or webinar on behalf of Sir Salimullah Medical College and Mitford Hospital. Then I have seen two foreign delegates or foreign speakers, Dr. Abi Al-Husseini and Dr. Reshma Barua. Both of them are very well known to me, and virtually they are the family member of my university. I must congratulate them, and I must wish them that they have presented very nicely, and we are really charmed with their presentation. Thank you very much, and I must congratulate you again. Then Dr. Professor Abdul Qadir Akand, he has really given a light, though later, about the right heart failure, which was a really neglected chapter before. And we are always busy with the left ventricular failure or left heart failure. But today, he has given many idea and clues regarding the etiology and the management of right heart failure. I must congratulate again Professor Abdul Qadir Akand, and not last but or least, Professor Upendra Kaur. He has given a nice lecture, and virtually we are really crazy of a new drug for heart failure every day. And today we have got the news that DAPA is a new drug for heart failure, even without diabetes. So many thanks to Professor Upendra Kaur. And again, I want to express my thanks and gratitude to all the speakers for their nice deliberation. Thank you very much.
Thank you, sir. May we listen to Dr. Shuk Nayar. He is the President of Royal Society of Medicine Cardiology Section and Communication Lead, British Cardiovascular Society. Dr. Shuk, can you tell us something about the latest pharmacological treatment of heart failure and your experience in the COVID pandemic?
Thank you very much. Thank you for having me on this wonderful webinar, and so incredibly well delivered. Great to hear really clear and passionate talks from all of the speakers today. I work very closely with Dr. Resham Bura and Dr. Abi Al Husseini, and so I know them very well. It's great to see them on here and building the links with Bangladesh. I'm an interventional cardiologist, and just a few comments on kind of things that we've seen recently. We've certainly seen a big increase in heart failure related events in the COVID era, and we've also seen a number of patients needing pacemakers quite urgently. One of the other panelists was commenting on patients suddenly decompensating with COVID, eye implant pacemakers, and certainly over the last few months I've had to do a huge number in patients who've had COVID-19. This is, I think, an important factor that's unrecognized. There is also sudden arrhythmogenic death that can occur unexpectedly in patients with COVID-19. We don't fully understand this. It happens also in young people. We've had a couple of cases of patients going home and then having an arrhythmic event. To answer your particular question about the new pharmacology in heart failure, I think much of it's been discussed already, but the key new developments are the addition of the SGLT2 drugs. These drugs at the moment, dapigliflozin, are absolutely key, and we will start to use these in routine practice, I'm absolutely sure. As Resham has already said, there are licensing restrictions here in the United Kingdom about their use in non-diabetic patients. However, we are beginning new studies to use them in patients without diabetes, much like DAPA, and we're also beginning to look at studies that will use it in post-myocardial infarction patients, so again, extending their use. These appear to have big benefit. You can see the curves diverge very early, implying that they have a benefit that's over and above a simple diuretic effect. There seems to be something very special about these medications. The curves continue to separate over a long period of time, implying that the benefit continues to accumulate. And so it will fall on us as cardiologists to identify the patients who can take these drugs, start them, and then educate them on their use. I think, as Resham has pointed out earlier, sick day rules are very, very important. This is something that has caused patients to have complications. And in our hospital, we've now developed a protocol to explain when patients should discontinue these drugs. For example, before performing an operation, a surgery, or even a procedure like an angiogram when patients are nil by mouth, and then also when they are unwell for other reasons. The other component is we must educate our emergency care doctors. Those in accident emergency must remember, if they see patients on an SGLT2 inhibitor, then they should check the ketones, because euglycemic diabetic ketoacidosis can occur in these particular patients. But this is an exciting time. I suspect we will see huge benefits in patients with the addition of these drugs over and above what's already used in heart failure.
Thank you, Dr. Shuk. May I request Professor Abdullah Shafi Mujumdar sir to say a few words for us? Professor Abdullah Shafi Mujumdar sir, are you with us? Sorry, probably he is not with us. May I request Professor M. Nazrul Islam sir to say a few words regarding these topics? Professor Nazrul Islam sir.
Sir left the program. for any
Okay.
urgent business. So
Okay, sir. We have got Professor Mohammed Jalaluddin, sir, one of our senior cardiologists. Sir, would you please tell a few words for us regarding this?
Are you hearing me?
Yes, sir. We can hear you, sir.
I thank Professor Abdul Qadir Akon and Dr. Firoz to arrange this program, the multinational program in heart failure. I thank Dr. Mounujaman to start with the cardiac failure center in his hospital. One thing I stress that there should be one cardiac rehabilitation center in everywhere where there is heart failure center, because at discharge from hospital, the patient should have a data of his condition, say about the ECG, what is the condition of the ECG, echocardiography, because at discharge, the ejection fraction may be something, but on follow-up, his condition may worsen, and later it has to be seen periodically, the ejection fraction, whether how it is it like before or it has decreased. And another one is exercise capacity should be seen on treadmill, that what is his capacity of stress, taking the stress, because after going home, he may be in some office professional work, or if it is very severe, he may remain at home, but his exercise capacity should be seen, because whether how much exercise he can take, and that can be assessed for the condition of the heart failure, severity of the heart failure, and also whether he develops any arrhythmia, malignant arrhythmia, to because the heart failure patient may die of ventricular tachycardia and ventricular fibrillation when the ejection fraction is very low. So in these patients, it can be diagnosed that these patients are having arrhythmia with stress test, then device treatment may be given. And so I my advice that whenever there is any heart failure center, there should be a rehabilitation center also. Thank you very much. I thank Dr. Abdul Qadir once again. Thank you.
thank you, sir. Firoz, please unmute yourself.
Thank you, sir. We have got Dr. Munjur Shaukat with us, who is also a student of Sir Salimullah Medical College, now working in Hammersmith Hospital, UK. Dr. Munjur, say a few words for us. You have seen heart failure management in Bangladesh and UK. What are the points?
Thank you very much for inviting me on the panel, and it's a great success for Professor Abdul Qadir Akon, actually, and also thanking my friends and colleagues at Imperial. They all did a fantastic job, and this is kind of collaboration between these two countries. I do not have actually time to say many things. I have to actually leave in a minute. I've got another commitment. What I would say that from Professor Akon's talk, he mentioned about the non-pharmacological treatment or exercise. What I will tell people, all the doctors in Bangladesh, and like a heart failure patient, they are a fragile patient. Please do encourage to do some kind of exercise when they are at home, because a lot of them are very stressed, not going out because of lockdown. It would be good, whatever they can do at home. It doesn't matter how much they could do, but if they can keep themselves active, that will actually generate their immune system to produce more macrophages. This is one of the immune system for our own body. And I would thank Abby to become Women's Voice during her talk. It was a fantastic talk. Professor Upendra Kaur's talk is an amazing talk. And Resham's talks, well, I'm a big fan of Resham. And actually, I have invited her to talk on this webinar. And finally, Bangladesh has got a new friend, Dr. Suk. I think probably Suk has sent a message across. And you, on this webinar, Bangladesh, good news for Bangladesh, you got a new friend. And finally, it is a good time to think about Bangladeshi cardiologists to develop Bangladeshi guideline for heart failure. Thank you very much. Thanks for having me. Thank you.
Thank you, Dr. Manjur. Thank you very much.
Dr. Firoj.
Yes, sir.
Firoj,
Yes, sir.
only a few seconds. Dr.
Yes, sir.
Manjur
Sure,
Shaukat.
sir.
Manjur Shaukat is my student, and he is working as a bridge between Bangladesh and UK. I must congratulate and give thanks to Dr. Manjur Shaukat.
Thank you, sir. Thank you, sir. I'm very proud to be your student. Thank you. Bye to everyone. Thanks, Professor Ali Akand and everyone, and thank you.
Thank you.
Thank you. Thank you. We are already late. If you have got any comment, may I request?
Can I make a comment?
Sure. Sure, sir.
I just want to say, Professor Kadir Akil sir has done a wonderful job. I didn't mention anything about that, but the subject he's chosen, the three different aspects of heart failure treatment, these are not the usual talk we are having during heart failure webinars. So 3 or 4 new viewpoints, different ways, presented beautifully, and we are really lucky to have him organize such a beautiful symposium. Thank you, sir, and thank you, your team.
Thank you, sir. Thank you very much for inspiring us. We have got Professor Babu with us. Probably. Left. Professor Mahur Rawan Babu.
Thank you, Firoz. Actually, I heard all the listeners, they are renowned, all the presenters, they are renowned in all over the world. Nice. I would like to thank for their nice, excellent, and time-worthy presentation. All the listeners should be benefited from their lectures, especially the fellows. I also congratulate Cardiology Department of Midford Hospital, especially Professor Abdul Kader Akon sir and Amirujaman Khan Lablu and all others doctors. And thank you all. Thank you, Firoz.
Thank you. Now, may I request Professor Abdul Kader Akon sir to conclude this session?
So now I'm taking the opportunity to thanks all those participated in the program. Today's presentation and discussion revealed a lot about heart failure. But truly, we see the tip of the iceberg. Unveiling major hidden part of the heart failure is a challenge, and probably it will remain for the future generation. I strongly believe the symposium organized by the Department of Cardiology, Sir Solimullah Medical College will benefit most of us and demands the periodic arrangement to continue the updating of our knowledge in the management of not only heart failure in other fields as well. My heartfelt thanks and gratitude to Dr. Abi Al Hosseini. Probably she left the program. She is a nice guy. Always she is with us. She is our old friend, and she is so cooperative. Whenever we invite her, she participates in any program. Basically, she is an interventional cardiologist, but sometimes she works in BBC News regarding the presentation of cardiovascular disease in women. So her presentation goes to that part as well. And Dr. Resham Borua is our new friend. She is the consultant cardiologist and the director of the NICE guideline for the heart failure management in UK. She is I hope she will continue the friendship with us, and we will get the cooperation in future as well. I will try to keep touch with you. thank you again. Thank you from the core of my heart to take trouble to make the program a success. And lastly, I want to request Dr. Resham Borua to consider the right heart failure in the next upcoming guideline, nice guideline, heart failure guideline. And our another guest and panel of experts, Dr. Shuk. He is a very nice guy. I heard a lot about him and his talk and discussion as a panel of experts gives us more inspiration. And in future, I will try to keep him as a speaker in next program. And he is a very giant man. He is the director, Royal Society of Medicine, Cardiology section. So I express my thankful gratitude to him. And Dr. Munjur Shaukat, the son of the soil, we have got the right to claim him to do something for the nation. So even then, I want to thank him. Professor Nazrul Islam, Professor Abdullah Shafi Muzumdar, Professor Shazol Banerjee, Professor Muminuzzaman, Professor Atahar Ali, Professor Mir Jamaluddin was supposed to present, but because of sickness, he is unable to attend the program. Professor Abdul Wadud Choudhury and Professor Fazilatun Nisa could not attend because she had another program today. All are the high-profile cardiologists in Bangladesh. Their name is so famous that they does not need any introduction. So I thanks everyone for kind cooperation. Lastly, I have to thank our doctors of the department because they work hard to make the program a success. And last but not the least, I thank the Incepta Pharmaceuticals, especially Dr. Riyad and Mr. Afsar and his team for technical support. So I thanks everyone for participating in the program to make it a success. And your encouragement will encourage us to make the program again and again. Thank you very much.
Thank you, sir. Thank you.